My name is Misty Blevins with the National Rural Health Association, SC. I want to take this opportunity to welcome each of you to today's webinar, Telemedicine for Rural and Critical Access Hospitals, Improving the Quality of Care for Rural Patients. Welcome to this educational webinar. We are unable to provide CEUs or CPEs for this session. Certificates of attendance will be available upon request for attendees who register, attend the entire webinar, and participate in all poll and survey questions at the conclusion of the webinar. Attendees may use these certificates with third-party organizations or their employer as documentation of having received an hour of webinar instruction. Please note a survey will automatically pop up on your screen as the webinar ends. NRHA partner educational webinars are recorded, and an on-demand link will be sent within 24 hours to all who registered for the live webinar. Please note that throughout the presentation, all participants will be placed on mute. If you need to communicate with the webinar organizer during the session or have a question for the presenter, please use your question box at the bottom of the GoToWebinar control panel. At the end of the presentation, we will have time for a Q&A session and answer all questions at that time. I would like to now turn the presentation over to Carrie Dostie.
Hi, thank you, Misty. I'm Carrie Dostie from AMD Global Telemedicine, and I'd like to personally welcome you all to our educational webinar on the use of telemedicine for rural and critical access hospitals. During the presentation today, you will learn how to reap the benefits of telemedicine to improve rural patients' access to health care. Before we begin with our presentation, please note all attendees are muted, as Misty said, during the webinar. However, we will have a 15-minute question and answer session at the end of the presentation. So feel free to submit your questions. As you can see here, I've circled on the control panel, there's a question box. So if you type in your questions, we'll try to address as many as possible at the end of the webinar. The webinar is also being recorded, so a link to the archived webinar will be sent tomorrow in a follow-up email to all participants. Today, our featured presenters are Jason Peoples, the Regional eHealth Coordinator with Carle Foundation Hospital, Harry Brokus, CEO of Carle Hoopeston Regional Health Center, and Brian Arkwright, Senior Consultant at Subsidium Healthcare and also former Director of the Center for Telehealth at Mission Health. Today we're going to start with Jason Peoples. He's going to start talking about basically how to implement a telemedicine program and lessons he learned along the way. Jason?
Hi, good afternoon, everyone. My name is Jason Peoples. I work with Carle Hospital. We are an organization that's located in East Central Illinois, and we really are a tertiary care center in our region and support a lot of rural areas, rural patients that are seeking a higher level of care. So I thought we would start off by just, really defining what telemedicine is. And defined by the American Telemedicine Association, telemedicine is the use of medical information exchange from one site to another via electronic communications to improve a patient's clinical health status. Benefits include improved access to patients, but also enables providers and health facilities to expand their reach. Cost efficiencies include reduced travel for patients and providers, reduced hospital stays, increased efficiencies in access to care, improving management of chronic conditions. Additional benefits include improved outcomes through patient compliance and increased patient satisfaction as well as provider satisfaction as well. That can be achieved via telemedicine. Another key driver is patient demand. Telemedicine enables access to providers and services that are not available locally, really removing the distance as a barrier to that higher quality of care. Additional strengths, we look at the delivery of integrated technological health service solutions, so that's really the foundation of the telemedicine platform. And we talk about the foundation, we really look at telemedicine as a way that we can start small and we can add additional services as time passes built on those successes. So we have the ability to use these platforms to think outside of the box to create services and utilize the technology that we have for other service lines and applications. Also, additional strengths would be looking at distant learning education events offered through regional partner facilities. So this would be through traditional means of video conferencing. We're able to provide an audio and video component as well as presentations, grand round surgical services, things like that can be offered to our regional partners that may have to travel a distance to receive that same education and receive those CME credits. So really looking at ways to leverage the technology to do things we haven't done before. Education is always a key factor. So start small, but think big. You circle back to 2011 when we had our telemedicine program here at Carle. We started with 2 different service lines. That included sleep medicine and pediatric surgery. Fast forward to where we are in 2015, we offer 10 different service lines, and we look at these service lines that we have at Carle as billable and reimbursable services. That's not to just limit the amount of innovative solutions that we offer, but we also look at in line with population health, with that PCP really being the center of that care, being able to reach out to the different specialists, access those resources so that that care to the patient can be provided locally. So again, we build on the successes that we've established and really look toward the future in healthcare. How to implement telemedicine. So some of the key points I'm going to discuss is we're going to look at the drivers to the building a sustainable program, how telemedicine equipment and technology is used to deliver care, and then the lessons learned from Carle's current program that we offer. So as we look at key factors in implementation and expansion, the support of the technology, it really begins with the personnel, identifying the key players to work with and educate the providers, and look to that key person to provide support from development of the program all the way through implementation. Ease of use is always a key factor with any sort of technological solution. Anything that we can do to simplify the complexities and enforce that ease of use to the physicians and to the clinicians that are actually handling the equipment, that is always of the utmost importance, at least in my mind. So then we look at translating the complex systems into simplified technology, and that truly is making a difference in making telemedicine an extension of that provider's practice. Additionally, looking at engaging IT support for discussions on network connectivity and network support. So some of the technological solutions that we have are web-based, they're on computers. This all will tie in with an IT infrastructure. So we look at what we would need, the bandwidth, we would have to look at the firewall, and then the relationship that we have with that regional facility to make that audio and video connection. And then how we get started, administrative engagement and support, we look at that commitment to telemedicine and really what it can bring. Technology over the years has really come down in price even and flexibility with what we can do. The age of video conferencing is here today on our mobile devices. So it's not a foreign concept anymore to make a FaceTime call, where traditionally having a cumbersome video conferencing infrastructure to have 2 people make that connection and make the test calls prior, some of those days are behind us. Of course, we want to always ensure that we have that connection prior to any sort of distance education learning or even before we implement a telemedicine service line, but really we need that commitment from the organization as part of the strategic plan, and to look at regionally how we can leverage the services and the partners that we have to offer services to those patients that otherwise would not have that availability. Physician champion, identifying a physician champion that can speak on the successes of telemedicine to their peers and identify additional opportunities of growth. I think that speaks volumes with physicians actually having this technology in their hands and speaking to the benefits of it and able to make a difference in those patients' lives. And when we think about it from the patient perspective, having to travel a distance to receive that high-quality care, that they take time out of their day, of course, to do that. Sometimes they're traveling to a larger metropolitan area. There's a lot of anxiety and frustration that can go along with that, even traveling to a larger city, whether that's 100,000 people or 1 million people. So that, looking at it from the patient perspective, I think that keeping that in line with how to get started is another key factor. Additionally, we want to engage partnerships with those regional facilities, look at what the service gaps are, what we can do to offer coverage, and then partnering with those facilities, that the critical access hospitals, the rural clinics, and skilled nursing facilities, to again, looking at opportunities to reduce costs for the healthcare system. From a skilled nursing facility, we look at that as maybe an unnecessary transfer to that facility that could have been avoided if we had had the access to that specialist or routine follow-up care via telemedicine. Additionally, looking at how to get started, we want to look at identify the outreach needs. Again, we're going to talk about the gaps in the coverage for services needed but not offered locally. Again, looking at that from the patient perspective, I would love to receive that care locally versus travel a distance to a larger area that I would have to take time out of my day for. And sometimes that could be half a day, so again, really focusing it on the patient perspective. And while behind the scenes, partnering with your coders in the revenue cycle, they play an important role in providing appropriate telehealth codes and what services are billable, as well as reimbursements. So you want to check with your local payer mix to understand what services are not only billable but reimbursable. While I say that as a key point, I also want to divert from that for a minute just to think about not everything that we do via telemedicine necessarily has to be a billable service. So we look at some of the programs that we've introduced here outside of our billable services, such as dietary consults from our inpatient dietitians here to other facilities that would need the access to that dietary consult that's not necessarily a billable service. Another program that we've been able to build from would be our NICU transport team. It is an expectation that our NICU transport team will take a device with them to regional facility as baby, who comes whenever they want to, that in the event that they would need to receive that higher level of care, would be transported back to Carle. Our NICU transport team, they take a device with them and they connect mom, dad, and guardian to the accepting neonatologist just as a peace of mind and more of a patient satisfier. You've just had your baby, baby's being packaged up, put in an isolette, taken a distance. Again, this is a way that we can leverage the technologies and really make a difference with the patients. So moving on, we're going to talk about assessing telemedicine equipment needs. Equipment solutions are paired with clinical needs. The use of mobile carts, wall units, smartphones, tablets, and portable cases, these are all devices that we use to make that connection via telemedicine. In most cases, consulting provider could be on a computer of some kind, and they'll have a web portal or video conferencing software solution that would enable that connection to the patient at that far end. So also video conferencing needs, we just kind of touched on that along with the distance learning and the education. Traditionally, we use video conferencing technology to provide that connection. In some cases, video conferencing technology has really just been repurposed for telemedicine applications, so that's certainly applicable into a lot of situations. And then in offering education to those facilities, we want to look at sharing content to also provide that voice and video with that component. So as well as we want to look at the existing IT infrastructure, so we want to work with IT staff to understand the existing infrastructures, the current capabilities, what those capabilities are, and the services that can be offered, and then that may introduce gaps with what we would need to introduce into that video conferencing infrastructure so that we can purchase equipment and provide those needs to the service. A lot of these systems are becoming integrated with your telecom system, that it's all becoming voice and video and presence all in one piece. So it's not necessarily just one piece for video conferencing, it's all becoming one. So interpreting diagnostic services, the diagnostic equipment used by the clinician with the patients provide that hands-on piece. The equipment captures the diagnostic information and provides real-time medical images along with voice and video to that remote provider. So that really groups everything all together. We're able to have the hands-on, we're able to have the physician consult, and we are able to have patients interact with their provider remotely. Communicating diagnostics to remote specialists. In our applications, we utilize a web portal and video conferencing software in certain situations. And we also use an electronic stethoscope for those heart and lung sounds. We use an exam camera, we use an otoscope. And we use those for quite a few of our applications that really require the hands-on. Some of the service lines that we offer that we're using the diagnostic equipment would be nephrology, cardiology. We use it for pediatric surgery. We use it for our sleep medicine. We use it for pediatric behavioral health. These are more of those clinical applications that don't necessarily require, that require more than just that face-to-face component. So we're able to connect that remote provider with the patient through the web portal and or the video conferencing software, and this really provides that simplified solution. We look at that one-stop shop for the medical devices and the information to be accessible on demand, and that's really where the shift is going toward with telemedicine, is really having that on-demand service so that you can have that service where you want it, when you need it, wherever you may be. So moving forward to lessons learned, we really want to focus on building on that success. The successes that we have built with those small programs, word of mouth. We at Carle, we have fought the good fight over the years where we have identified certain opportunities and certain areas of interest with our regional partners where they otherwise wouldn't have those services available. So we look to having that information and partnering with those facilities to provide those services that they otherwise would not have. So again, it all starts somewhere, and you can absolutely build on those successes with the programs that you are offering. And then clinical staff and provider willingness, this is also a key component. So with clinical staff at certain locations, again, we want to not only leverage the equipment, but we can leverage the staff as well, who are our super users, who are using the telemedicine equipment, who are that friendly face to those patients in that local area that can speak to the technology and the benefits that it has. Provider willingness, obviously, is a key component as well. Not only having those providers that understand the technology, but the willingness to use it and have that light bulb really go off in a sense that they can have that desire to use the technology, again, simplifying that technology, using it as an extension of that provider's practice to make it part of that plan of care with that patient. And that really goes back to identifying certain patients that fit a certain criteria for those telemedicine visits. Our telemedicine visits for every patient? Not necessarily, but that's the beauty of it, is that it doesn't have to be. Patients that fit a certain criteria would absolutely fit the bill. They could receive that care locally versus waiting weeks or months in some cases, depending on the service line and the access, to receive that care. Additional opportunities gained from telemedicine. We create the brand awareness to gain the market share by providing patients with convenient access to those providers and services. The collaboration with the regional facilities to provide that exceptional quality of services to a broader geographic location. Again, partnering with those facilities, listening to what their needs are, working with that organization to determine what can be offered and when. Usually in my world, the technology is the easiest part. It's the credentialing, it's the workflow. In some cases, crossing state lines, it's that licensing that can become a barrier. But once you have those pieces in place, telemedicine programs, they're relatively easy to get up and running. And I kind of stress on that term relative depending on the organization. Additional opportunities, innovative models for delivering care while improving on coordination and overall patient experience. So again, looking at the traditional telemedicine applications, those solutions, and how we're able to build on those successes, utilize different platforms, utilize different technologies to deliver that patient care experience and enhance that patient's care, improve their compliance by receiving that care locally. And in some instances, we've even received feedback that says, hey, I feel like my physician, my provider, spends more time with me on a telemedicine visit versus a face-to-face where they feel like they're rushed or they have to get to the next patient into the next room. So really shifting that paradigm with how patient care is delivered. And looking at additional resources for telemedicine, I use the Department of Health and Human Services very regularly. There's an annual guide that I use that comes out every year that provides lots of information. It provides all the details with the originating sites. So it outlines what the originating sites are. It outlines the assistant practitioners that are able to provide those telemedicine services, the telehealth services that are offered, as well as the billing and payment for professional services and the billing and payment for the originating site fee. So that all breaks down everything that you're going to need to know. It groups those codes together. So again, partnering with your coders and the revenue cycle team to put those codes into certain EMR systems to be able to put those in that charge capture. So when that patient counter isn't closed, it's really no different than it would be for a face-to-face encounter. So that's more work behind the scenes, but it's definitely a key component as well. So we've included a link at the bottom. I think that we'll share this in the in the information that we share at the end of the program, but that's definitely a reference that I would encourage you all to take a look at.
Thank you, Jason. And next up, we have Harry, and he's going to start talking about the positive impact telemedicine has made on patient care at Carle Hoopeston Regional Health Center and his personal experiences with their program. Harry?
You know, Harry had to step out for a minute, so we're going to have to kind of punt here and forward to Brian.
Okay. Okay, so Brian Arkwright is going to talk about the telehealth funding and strategy considerations for rural hospitals and his experience with finding funding in unique places and growing telemedicine programs. Brian?
Thank you very much, Carrie. I'm very excited to talk today, and thank you for the opportunity. A little bit about Subsidium Healthcare and my background. Subsidium specifically has a dedicated team for telehealth, and our team only focuses on telehealth projects. And we are doing everything from workshops for health systems and independent hospitals, rural facilities, rural health systems, to business plans, financial models, all the way to comprehensive health strategic plans for telehealth initiatives. We also do implementation and operations, so we can write the business plan and help a health system implement and operate it as well. So if you're looking for any type of additional horsepower in any of those areas, don't hesitate to reach out to us. Prior to joining Subsidium Health, I was director of Mission Health Center for Telehealth in Western North Carolina. They were a 7-hospital health system located in Western North Carolina, a very rural area, and we helped them grow from a total of 8 sites and 4 clinical programs when I arrived to today they are approaching 50 sites. They have 15 clinical programs, including acute care. They have a lot of outpatient programs. They also have remote home monitoring and mobile health programs as well as part of their portfolio. Just to give you an idea of the volumes associated with those sites and programs, they have grown from 655 video visits a year to the following year of over 2,000 video visits, and then the year after that, we finished the year with 3,200, over 3,200 video visits, and then right at the time I was leaving, we had just finished a quarter of fiscal year 15, and we were projected to do over 5,300 video visits. So very similar to Jason, lots of growth, lots of exciting programs, telestroke, telepsych, employee telehealth, telebariatrics, and school-based telehealth were some of our top programs. And so with that, we can kind of get into the topics covered today that I'm very excited to share with you. The first being telehealth funding sources. There are a number of funding sources, and I really want to kind of open the cabinet to kind of look at those that are local and then those that are beyond. So some of these may not be top of mind when you're thinking about funding sources for telehealth, but it's something that is very important and can really, when you talk about growing a program quickly and having that speed that a lot of health systems and hospitals are looking for, funding sources really can open the door to that. The next topic I'll cover is leveraging relationships with other hospitals. In the past, I've spoke on partnerships being a key part of telehealth. As often, there's a hub-and-spoke model. So we'll look at how a rural hospital or facility can leverage relationships with other nearby hospitals or health systems, and some of the important points to consider when considering a relationship. The third topic we'll cover are value and benefits of telehealth. They indeed outweigh the cost, and we'll look at some of the reasons why the value and benefits outweigh the cost. And then lastly, we look at tracking telehealth news and trends. As you know, many of you on the call and the panelists know that telehealth has really blown up is really grown phenomenally in the market. So being aware and having your eyes set outside your organization of what's going on in the market, your local market, and nationally and internationally as well, is a great place to keep your eyes and ears to watch. Funding sources for telehealth. So many of you are probably aware of the federal grant. There's a number of programs out there through the USDA, through HRSA, through AHRQ. Many of these are excellent sources for telehealth funding to get a program off the ground. There can be challenges in the timing and detail. Many times these federal grants come out and you have 10 to 12 weeks until they are due. And then the detail associated with those can be upwards of 50 to 100 pages of detail, multiple attachments and appendices to include everything from getting the floodplain on considered locations to letters of support. So that the timing and the detail can be a challenge and a barrier. If you do have, I will encourage the group that once you have put together and formulated a vision for what you want your telehealth program to be or a telehealth strategic plan, it makes applying to these federal grants much easier because then you can quickly tell if, yes, this fits and aligns with my strategy that I want to do for telehealth, or it does not, and the overall health system or hospital. So I encourage folks to really understand what they want their vision and plan to be, and then applying to these federal grants can be much easier. It does take time, so we do encourage you to kind of partner with other internal resources of your organization, and there's a lot of great grant writing companies and organizations out there that can help a health system or hospital write a compelling grant. The next is statewide Medicaid initiatives. There are a number of Medicaid initiatives across the country that are looking for innovative payment reform programs. And telehealth really fits in with many of those program requirements, whether it be the hospital, the rural setting, increasing access to a needy population, et cetera. And like Jason mentioned in a lot of his points, keeping an eye on those needs and what your state's looking to do, there can be really good funding opportunities with Medicaid. I know for one example is New York's DSRIP program, or DSRIP for short. That's a great program, and feel free to research that or reach out to us if you would like more information. But it's a innovative payment reform model, so it's a great opportunity for hospitals in the state of New York. And there's other examples like that across the country. The third bullet point there is your hospital's foundation. In my past experience, we had a phenomenal relationship with the hospital's foundation. And when you were entering into an era of where hospitals have increased costs, decreased reimbursement, and philanthropy is really becoming a key theme and key focus of hospitals and health systems. So, reach out to your hospital foundation, see what their philanthropy goals are, because, if you're talking to major donors, or oftentimes the hospital foundation is very in tune with local grants and endowments, so they may already have that relationship, and they may be the first ones to hear about a new opportunity or a new grant program. But implementing a telehealth program, like Jason mentioned, buying a cart, some peripherals, setting it up at a rural clinic, these can be things that can be done relatively in a quick manner, and so a donor or philanthropist can see their money at work quickly, and then see an impact quickly of reaching a needy population, increasing access, decreasing costs. So I really encourage groups to explore their own hospital foundation and see what collaborations are possible. The fourth bullet there is local and statewide foundations and endowments. My last experience, we had a lot of success working with statewide foundations and endowments. everywhere from, one example that funds programs in North Carolina and South Carolina is the Duke Endowment. And then there are other, if you look at the large organizations, or if you have any Fortune 500 or 100 companies in your state, oftentimes they have a grant program or some initiatives that look to fund local projects related to healthcare. There's a Facebook data center in North Carolina, in rural western North Carolina, and that was it was a 500-word grant program that the opportunity was to get $10,000. So there's all sorts of examples out there, and I really encourage to don't leave any stones unturned, and look at those statewide foundations. Understand the timing. Oftentimes these local and statewide groups, their requirements on the detail is less than a federal. So you're looking at maybe a 30 to 40 page initiative and proposal versus a 100-page proposal. And also their timing, oftentimes you may have 3-4 months to submit something, or they have annual cycles or quarterly cycles, so you can kind of just plan to hit one of those cycles that works with your timing and game plan. The fifth bullet there is Rotary clubs. Rotary is a very localized national civic organization, and I believe they're coming up on their 100-year centennial initiative. So they are looking to fund different initiatives. If you may even have Rotarians in your organization, on your hospital board, coworkers might be Rotarians. So that's another area to consider as well, very similar to the local and statewide groups. And then the last bullet there is volunteer organizations and groups. Very similar to the different local foundations, you may have large civic groups or volunteer organizations in your area that have pools of money that are looking to fund innovative, action-oriented, cutting-edge initiatives. And telehealth, by all means, follows in all of those categories. So one example, in my past, there was a volunteer fund at the hospital, and we wrote a grant and a proposal to that volunteer fund, and we had a cart and a outpatient clinic room set up for telehealth in the amount of about $25,000, and the volunteer group funded it. So another, great, probably not always thought of group to consider going to get additional funding. So lots of good sources there. This next slide I'd like to talk about is leveraging relationships. Partnership is a key word. Collaboration is key with telehealth. Oftentimes you're, connecting, as Jason, mentioned the definition, you're connecting over, vast distances. So when we tell hospitals and to think about this, the first thing we do is ask, what are your greatest needs? Do not let, do not let a vendor, do not let another health system, do not let a competitor, don't let them tell you what your greatest needs. Look internal, do some self-reflection, and identify what are your greatest needs. What is the hospital strategic plan over the next few years? What are your opportunities? What are where are the areas that need more access to care? Are there new revenue opportunities? So we really encourage folks to look internal. The next bullet is, what are other hospitals doing nearby? There may be a new telestroke program that a health system's launching, and they're looking for an additional site. This is a wonderful opportunity to kind of look at others in your state to consider who's doing what, and does that fit and align with your greatest needs. The third bullet there is exploring partnerships, site expansion opportunities. So, similar to what I mentioned about, maybe somebody's starting a telestroke program, maybe somebody's starting a telepsychiatry program. Look at those, talk to those hospitals, see what their expectations and goals are, and determine if that's an alignment to you. There may be significant infrastructure and hardware costs that a local hospital may not have to come up with because they're partnering with somebody else, or that partner may cover some of those infrastructure and hardware costs. Maybe they have a grant to put equipment at your location. So there's all sorts of opportunities and benefits to leveraging relationships. And then the last bullet there is an example. In North Carolina, there are both two very successful, and the market is flush with both telestroke and telepsychiatry. About 3 or 4 years ago, there were 2 health systems that did telestroke. Today, there are over 10 health systems that do telestroke in the state of North Carolina. 3 or 4 years ago, there were 12 locations. Now there's well over 60 locations with telestroke. So if you're a hospital in North Carolina and you don't have telestroke, you have lots of choice of what health system you may want to partner with. And very similar in other states, that may be the case. A second example in North Carolina is telepsychiatry. I served on the advisory board and helped implement and launch the North Carolina telepsychiatry program, also known as NC STEP. NC STEP is a program that actually started as a Duke endowment. It was at 11 hospitals, and then the governor of North Carolina said, this is great, what do we do to expand it? We helped write a comprehensive plan that the North Carolina state budget approved $2 million in 2014 and $2 million in 2015 to implement this statewide initiative. Today, that program is at 67 hospitals. It's estimated to be at 90 hospitals over the next 6 to 7 months. So if you're a hospital in North Carolina, you have the opportunity to look at the NC STEP program and get telepsychiatry 7 days a week for a nominal fee. It's a phenomenal business model. And so, you know, if you're in other states outside of North Carolina, you know, maybe there are statewide initiatives similar to that you can benefit from. That program, as it launched, it took some time to kind of spread across the state. Many hospitals and health systems weren't aware of it. So if you go out and do some research, you may find something like that in your state. The value and benefits of telehealth. They do indeed outweigh the cost. I'm not going to read through all these. Jason touched on a lot of this. Harry's touching on a lot of it as well. But just, you know, if you think about your own organization, I'm sure that if you were able to keep more of your patients and reduce the length of stay and reduce patient readmissions, you'd be in a better situation. You would have positive results at your organization. You know, more effective disease and chronic condition management is something that has really been getting a lot of focus with the baby boomers aging. Access. You can't say enough about improved outreach, earlier patient diagnosis, and other things. The last, you know, there's new revenue streams often associated with telehealth. And something that is very popular right now and growing exponentially and there's a lot of alignment, is the Accountable Care Organization, or ACO. ACOs and telehealth, if you kind of think of a Venn diagram, those two areas are really starting to overlap a lot. So if your organization is looking at ACO work or becoming an ACO, or they already are an ACO, telehealth is an excellent way to kind of ramp up your horsepower. And then just my last slide is how important it is to keep your eyes outside of your organization and track the latest telehealth news and trends. There are new programs popping up every day. I am very avid on Twitter and Google+, and if there has been a telehealth article or a new program or a law or a bill that's been proposed, chances are I have posted and shared it publicly. So these are good resources to track, but we also encourage organizations to track and keep their eyes open. You may see something, you're a hospital in Iowa, and you may see something in Mississippi that would be perfect for your organization. So kind of looking at what's already been done. Also, I'd like to mention that hospitals and healthcare are probably one of the most collegial industries out there. So if you see something posted on a hospital in Iowa, you do not hesitate to reach out. Telehealth and the professionals that do telehealth is a very small group, and we're also very collegial. So don't hesitate to reach out. There's probably a director of telehealth or regional coordinator like Jason who's happy to share what they've learned. And that concludes my time. Thank you very much.
Great. Thank you, Brian. We're going to actually go back to Harry, so just give me a quick minute to pull up his slides. Harry, I'm assuming you're all set to go?
I am here. Thank you.
Great. Okay. Sorry for the delay here. Okay, and Harry is ready to talk about how telemedicine has impacted his program at Hoopeston Regional Health Center. Harry?
Good afternoon, everybody. Thanks for allowing a change in the program and order of speakers. I'm Harry Broncus. I'm the CEO at Critical Access Hospital in Hoopeston, Illinois, which is located 50 miles away from our tertiary provider. We have 25 inpatient beds, 9 rural health clinics. We see over 200,000 outpatient visits a year in those rural health clinics. And participate in clinics as far away from our primary source hospital as far as 110 miles. We're an agricultural community with a base population of about 5,300 people, declining and aging, as most of you probably have in your rural communities. We have a high incidence of chronic disease in our community, specifically diabetes and heart disease are extremely prevalent amongst our patients. We have very limited access to specialist care. The tertiary provider being 50 miles away, windshield time for a provider to come and visit us would be 2 to 2.5 hours. So we look at the positive impact that telemedicine has had on our rural hospital and clinics. We started using this based on the needs of our patients. Many of them were coming in and talking to us about how their cardiologist was over in Champaign, or in other words, 50 or 60 miles away, and having to go great distances, not always having to get a daughter or a son, somebody to take off work to help maybe drive them over there for the different types of procedures they would need. And so we started to look at this overall and thought that telemedicine might be a way to move forward and really improve the type of care that we're providing in our community. And it ended up, we started out with radiology and then turned to digital mammography and then on to many other services. We now provide OB, maternal fetal medicine consults in our emergency room be using telemedicine. Our dietitian in the hospital is actually via a telemedicine connection with a tertiary provider. Then we provide cardiology follow-up, nephrology follow-up, and other follow-up services available within our clinics via the telemedicine connection. The impact it's had to our community has been an improvement in access for our patients, which we'll get into what some of the goals that met as we move forward, as we've studied it out over the last few years. It is all about the patient, and it provides better access. So doctors don't have to spend that 2 to 2.5 hours on the road, which means they can do a telemedicine visit and then get back to their primary clinic, all within a very short time frame, which means they're more willing to block some time for telemedicine visits on a weekly or daily basis, that we then have a nurse provide telemedicine services at the remote location using the equipment that was provided to us through the Flex grant program through our local Illinois Critical Access Hospital Network. Along with that, it improves patient compliance. One of the things we noted that patients become non-compliant when they don't see their physician on a regular basis, or it becomes too difficult to see their physician, it's too difficult to receive an appointment. The telemedicine concept allows for them to come to a room, be seen by the nurse, everything set up, and having the appointment with the doctor and everything be over in 20 minutes. It gives that face-to-face contact that they need for the doctor to encourage them to maintain their weight loss, to take their medications, and be compliant with the treatment program. So instead of seeing their doctor once a year, they can see their doctor 2, 3, or 4 times a year as required to help them continue to manage their chronic disease. So those are the important patient impacts that it's had. Of course, there are other things as well. There is cost. The cost of a telemedicine visit is less. It does reduce the cost of health care as patients don't have to travel. It's better for them. It's also good for the doctor in terms of their doctor's productivity. His productivity is improved by not having to waste time during travel. Some examples at Hoopeston that we've used of telemedicine. First one I would talk about would be digital mammography. When I came to Hoopeston 6 years ago, we used analog systems. Took 5 days to get a result. We quickly bought a digital system and went into an agreement with the Mills Breast Cancer Center here about 50 miles from us. And we are now able to do digital mammography in a manner that a breast radiologist is real-time reading the diagnostic mammogram at the same time the patient's having the mammogram, and the result is actually given to her before she leaves the room. Imagine the kind of customer service satisfaction that creates. Somebody who's found a lump on their breast no longer has to worry for 4 or 5 days waiting for the result, but immediately has a result. And even if it is a negative result, a treatment plan is started immediately and additional appointments are made immediately. So it really improved the overall quality and the type of service we provide, and no more delays in care in terms of treating those diseases. The other one here you'll see is a cardiologist fall appointment. We had a 78-year-old female come to visit us. They wanted to see her doctor. And he said, well, I can see her via telemedicine, and it was just a follow-up appointment. She just wanted to make some adjustments to her medications and ask some questions. And he was able to do that via telemedicine, saving her the 100-mile round trip that it would have taken to get back and forth to the physician's office at another location. So we saved the family time, we saved the physician time, but at the same time, we just had a better overall health impact by making sure that she got what she needed in the immediate sense. And probably one of the more interesting ones we've had is the delivery of a baby in our emergency room. I like to tell the story. Most emergency room physicians would rather treat multiple traumas at one time than deliver a single child. And we have had the graciousness that we are connected via iPad to our maternal fetal medicine counterpart at the tertiary hospital. And so during the birth of this child, he was able not only to see the patient, but was able to communicate directly with the physician face-to-face during the birth of the child, while other resources were being brought up by ambulance for a premature birth. So that kind of backup system, being able to talk to somebody face-to-face and actually turn the iPad and show the doctor this is what's going on the other side, has been invaluable to the quality outcomes that we're able to provide in our institution. Now, appropriate care cannot be trumped by payment. I understand there are a lot of concerns about the lack of payment reimbursement for telemedicine services. What I can tell you is we need to do what's right for our patients. If we do what's right for our patients and improve quality, other things will fall into line over time. There are a large advocacy efforts going on at the state and national levels to allow for reimbursement of telemedicine services. I believe over time, as we continue to educate, that will lead to change. As we talk to our congressmen, talk to our state senators, talk to those people at CMS about the benefits of telemedicine and what it allows us to do, and how it improves access and patient outcomes, that it will lead to a change in reimbursement, allowing for it to be reimbursed. The great thing about telemedicine is it's available for any area of healthcare. You've heard me mention many here today, but there's many I haven't mentioned. And maybe I haven't mentioned the one that's a problem in your particular area. But if you'll sit down with a group of people in telemedicine, talk to your local hospitals, reach out to your tertiary providers, to your universities that may be working on this, you'll probably be able to find a solution in any area of healthcare that you have to provide telemedicine services that can improve things in your hospital. The other thing it does is help us to manage risk and produce better outcomes. So we're all working into a value-based environment. Even in rural, we will face that in the near future. We have to be able to continually manage risk. Doing it via use of telemedicine and electronics will be one way. I envision days where high-risk patients will have high beds in their homes, and they'll be able to connect to their nursing staff or their physician's offices and ask questions. And where nurses will be able to connect with them to make sure they took their Lasix for blood pressure, weighed themselves for the day. producing a better outcome, keeping people healthier, and living higher quality lives. I thank you for your time today, and I hope you have a wonderful afternoon.
Great. Thank you, Harry, for sharing your experiences with your telemedicine program. I'm going to move on to just skip ahead here since we had a little change. Okay, so Jason, Harry, and Brian all touched on so many great points on how to make telemedicine programs successful for rural applications. Before we move on to the Q&A session, here are some key takeaway points. As Harry mentioned, it's all about the patient. Keeping the patient care as the primary goal for your telemedicine application is clearly what's driving the best and most successful telemedicine program. Technology has to be easy. So as Jason attested to, you'll receive more support from physicians and users if the technology equipment is easy to use and simple to integrate into your existing workflow. So making it simple helps you get more buy-in from everybody else to use the equipment. And funding can be found in unique places. Brian had quite a few examples of some pretty unique pockets he was able to find funding or money or grants. And I think all of those are definitely useful for everybody out there, specifically for rural applications. So here are some considerations to keep in mind when choosing your telemedicine equipment and technology. The environment of the equipment. Does it need to be mobile, move from room to room, or set up and left in a dedicated room? These are all things, obviously, have to be considered when choosing the right equipment for your specific needs. Medical specialties you're servicing. What are you looking to provide, not just now, but also think about what would help you in the future, and look for equipment or technology that's modular or can scale with you as your needs evolve. And then, of course, training required of users. Less is more, so finding technology that is easy for people to use will make them want to use it more. And then finally, integration with existing IT infrastructure. You don't want your telemedicine to be a separate practice of care. It can easily be streamlined with your existing practices and workflow and technology. There's simple ways to make it all part of your healthcare delivery as opposed to a separate part of care. And this is the type of telemedicine equipment and technology that AMD Global Telemedicine is helping their customers with. Encounter management software, medical devices and equipment, telemedicine systems and mobile carts are all different types of equipment or technology that can be used in these types of applications. So now it's time for our question and answer session. I believe we have quite a few questions already compiled, and Misty will start reading them out loud. But if you have questions and have not typed it in yet, there's a box on the right-hand side on the control panel. Feel free to enter your questions in there, and we'll get to as many as we can today on the call. And also we'll try to provide a summary afterwards with some additional questions if we didn't get to them. I've also listed here the contact information for each of the presenters in case you have questions that you want to direct to them specifically. Misty?
Well, thank you very much, presenters, for this important message. We do have quite a few questions, so I'm going to go ahead and dive in. Is the telemedicine staff at Carle dedicated to telemedicine functions, or do you have other duties as well? And then there's a second part here. If other duties, what are some of those duties? This person asking the question is currently an IT director trying to start up a telemedicine program at their facility.
Well, this is Jason. I'm going to go ahead and field that question. You know, as far as other duties as assigned, I think it's always up to each individual to always have that other duties as assigned, so we can always get pulled away to do other tasks. As far as e-health, telemedicine, that is particularly my primary function and an area of expertise. I definitely partner with IT and work with others to make that connection, work with those regional facilities, their IT, and in some cases we work with, like for example, the Illinois Critical Access Hospital Network. They have resources allocated to work with the critical access hospitals and rural clinics, time allocated on a monthly basis to work with that local IT staff. So some of my efforts get bundled in with that piece, but it's always about coordination and collaboration. So in some organizations, I have come across that telemedicine, the e-health piece falls under IT. In our organization, it tends to fall outside of that division in strategic development. Other areas I have seen it bundled in with simulation and education. And what we're seeing more of a push for now is innovation. I think that all telehealth services all have a key component with innovation, but the backbone to all this technology is going to be that IT infrastructure and that component. So as far as organizations, I've seen it different ways. We happen to be unique as we live in strategic development.
Thank you very much. How did Carle's EMR fit into telemedicine consults?
Well, EMR being the backbone to being our medical record for our ambulatory care as well as our inpatient care, it's a way that all the documentation will live all in one place for that patient medical record. We use Epic at Carle, so that is our EMR platform, and the EMR companies are getting smarter and smarter. They are incorporating telemedicine technologies as a functionality within their EMR. So as we have a one-stop shop again, EMR companies such as Epic, they are offering support for video visits, which would be a traditional telemedicine visit all through the medical record. That could be done from clinic to clinic, or that could be done through a patient portal that EMR platform supports that would enable the patient to have a video visit from wherever they are, using that portal as that secured connection to access to their to clinical care, whether that's through a provider or even a nurse navigator for certain situations. So,
to what extent, if at all, did you utilize the services of your HRSA-funded Regional Telehealth Resource Center in setting up your program at Carle?
At Hoopeston, we utilized the flexibility grant program available to us through the Illinois Critical Access Hospital Network. That was enough to fund what we needed to purchase the equipment and set up the program. There are plenty of grants, as Brian indicated, plenty of program availability and grants being shipped out there for this type of technology and the purchase of equipment. Jason may have some other knowledge.
You know, we always get some grant invitations from the USDA. There's a RUS grant that's available. I think Harry and Brian have touched on some of the other ones. But one piece is that the technology has been simplified, and we've come such a long way to where we were to having a robust infrastructure that just supports video conferencing, again, repurposed for telemedicine, that we can achieve the same audio and visual connection through a web portal that doesn't require that robust infrastructure traditionally like we had before. Again, the utilization of mobile devices such as iPads, FaceTime does have a level of encryption that, interpreted by some organizations, meets HIPAA compliance. So that is absolutely a method of audio and video connectivity that we can use that eases the burden of the cost of that robust infrastructure that can be upwards from $100,000 to $250,000, depending on what vendor you go with, what the existing infrastructure is, and what you are trying to do, and how that plays a piece of the overall IT infrastructure with telepresence, with IM, with voice and video. All that seems to be bundled in one-stop shop. So we look at telemedicine funding. There's lots of opportunities and advantages that we have that we didn't have historically.
Thank you. Our next question is, are health plan payers involved in promoting telehealth services to their members?
Well, this is Harry, we're an integrated health system, so we do have that ability. We have a health plan as a part of our organization, and we have found that to be beneficial to us in terms of being able to go and speak to them about the use of telemedicine. They are, of course, supportive and champion the cause for us. Other payers, like the larger payers across the country, are probably going to wait until the government takes some action on reimbursement from the Medicare and Medicaid perspective before they venture into this. Those that are truly aligned with risk-based plans would be wise to do it before that, but profit seems to come before anything else for those organizations, and they struggle to move forward without some other reason to do so.
Yeah, something I'd like to add to that as far as the payers are concerned. Some payers are offering perks as part of their insurance plan that offer a video visit before a traditional office visit. So they're actually suggesting that you try a doctor on demand before you actually go into the clinic. It seems to be more compliance with the patient, but again, receiving that care locally. But again, it turns into that fee-for-service, that doctor on demand as part of that healthcare perk. And that'll be interesting to see how that takes shape in the future. Those are starting now, and as time passes, again, it'll be interesting to watch and what opportunities are available with how you can leverage that, and again, with the services that you offer. Chronic conditions are definitely paramount and in our minds right now, healthcare payers are taking that into consideration too for, let's say, an occupational med situation where it's not just, hey, I have a laceration on my hand, I need to go have this stitched up, but it actually leads to the healthier workplace in that environment, keeping those patients healthy, managing their chronic diseases remotely is something that people are looking at that's real. It's starting to happen today, and again, it'll be interesting to watch that take shape.
Yeah, nationally, I believe Oscar in New York is a health payer that has begun to offer those types of visits to their covered lives. And then a few years ago, both Aetna and United made different alliances with American Well and MD Live. And then separately, with many of the organizations we are working with, those that are an integrated, they cover their own lives. They're a health system that also has a plan. That is a huge driving force in programs and employee health programs. Is a program that we set up at Mission that was very successful, and it is really growing exponentially. So, and that's another area that is seeing a lot of growth and has a lot of value and a really strong ROI for hospitals and health systems.
Our next question is, what are the key factors that influence which service lines you've chosen for telemedicine services?
And this is Harry. I think the key parts of that are your community health needs assessment. We're here to serve a community, and so we need to look at the community and see what needs are not being met. We do that by surveying the community through the community health needs assessment. Also by reaching out to our patients and surveying them as they come through the doors. What other types of services are they going elsewhere for? Once you identify those things, then you can prioritize from there what types of services you would like to perform via telehealth. In other instances, it's a situation of not being able to hire a radiologist to be at your local hospital, situation of not being able to hire a dietitian at a small rural hospital. That brings up the need for these types of services, and you can reach out to your tertiary providers and try and develop some unique programs around that.
Okay, our next question is, if payers are reimbursing the follow-up visits the same rate as an in-person visit, then how do we justify that telehealth can reduce cost? If we don't reimburse it at the same rate, it may be a turnoff for providers wanting to make this a part of their workforce, since they'll be losing revenue.
This is Harry. I think the key to that is doing what's right for the patient. We're moving toward a risk-based, value-based society where we're not going to be concerned about number of people coming into our hospitals and our clinics for visits. That's a volume-based mentality that is going away quickly. As in Illinois, we will be 100% managed care, risk-based for Medicaid within the next 3 years. That's a large percentage of our population. So our focus really isn't on you coming into the clinic. Our focus is keeping you out of the hospital and keeping a healthier life. We're going to be given X amount of dollars to care for a patient. How you do that is going to be up to you. What's going to be left over at the end of that, how you spend that money will determine whether you have money to reinvest at the end or if you lose money on the care of that patient. So it does lower costs because it reduces the amount of time doctors have to spend in travel. It makes greater access to different types of specialists and improves compliance of the patient. So in a risk-based society, which is where we are moving, this is ultimately a direction that we need to be moving.
Those are great points by Harry. And in addition to that, in these rural, regional markets, no-show rates are a big thing. And when you start to cut the data of, all right, maybe our hospital or clinic is serving a 12-county region, and you start to look at the show rate or the no-show rate for a patient's second visit or follow-up visit, and by the further you get away from your clinic or hospital, the higher that no-show rate is. And in some examples, we were seeing 90% do not show up for their second visit from certain counties. When 9 out of 10 of your patients aren't showing up to their follow-up appointment, then you need to do something different. You need to make it about the patient, and you need to make it easier for them to access this care. And that's where telemedicine really comes in handy. And a lot of those points that Harry made of the value and the access, you can't make revenue if that patient doesn't come in at all. So that's one way where it drives out costs and is better for the patient and for the health system overall.
Thank you. Does the person operating the equipment have to be a nurse?
I would say not necessarily. We know how valuable our RN resources are, so for certain applications, yes. Other applications, no. In some situations, we have a certified medical assistant that's in the room with the patient for the duration of the consult. They're the hands-on. They're manipulating the electronic stethoscope, accessing the web portal. They are also using the diagnostic equipment, such as the exam camera, otoscope in some cases. They're able to work with the patient, give them a sense of ease. So with these telemedicine visits, we don't just room a patient and then have their physician beam on TV. We do have more of that. We want to be mindful of our patients in these smaller areas.
Those are great points, and I concur with Jason, where we were also using a lot of certified medical assistants. And, we looked at, you can look at telemedicine as an opportunity to improve the patient experience of where it is today. Because if you look at the baseline of patient experience and seeing physicians or nurses in person, at times it can be pretty terrible. So using telemedicine, using a CMA, high definition, better, maintaining eye contact, all of these things are opportunities to improve the patient experience.
Do the physicians providing the services have to be credentialed at the Hoopeston Hospital?
That is yes.
Okay.
That is a requirement of our medical staff, and anybody providing services in our clinics or hospital must be credentialed there. We do use deeming credentialing, which means that they are credentialed at our tertiary provider. We accept the credentialing information that they have on file. Process much quicker than a full credentialing process. And that is allowable in rural areas according to Joint Commission and DMV.
Thank you. Do the telemedicine physicians bill and get paid for their services, or do you pay them an hourly rate for their services, such as a purchase service?
I'm going to answer that. This is Jason. So it depends on the situation and really the needs and the partnership with that regional facility, what they're wanting to do. In some cases, it's a contracted physician at that regional facility providing services as that regional facility's physician and or specialist. So in that instance, they would be billing and charging from that regional facility. Other situations that we have encountered where we as in Carle are providing the consultative service via telemedicine. Patient is a non-Carle patient presenting at regional facility. In other instances, that it is a Carle patient at a regional facility having the consult from, I know this sounds messy, having the consultative services provided by a Carle physician. So in those situations that it's a Carle physician providing Carle services to a non-Carle patient or a Carle patient at a non-Carle location, there is a telemedicine consent form that is signed prior to any treatment via telemedicine or any interaction. And patient is notified that they will receive a bill from Carle for that consultative services based on the service line.
Our next question is, please describe the clinic workflow. For example, the medical assistant does the vitals, introduces the patient into the telehealth room, then what?
So in that instance, patient is roomed with the clinician, waiting for their physician to make that connection on their telemedicine equipment, whether that's through a web portal or whether that's through what I would call a traditional telemedicine card. And physician will make that connection. They introduce themselves as they normally would in a face-to-face visit. They are working with the patient, of course, just like they would with a face-to-face. Really the only difference is that the hands-on component is provided locally with that patient, with the clinician that's in the room. Again, they are the ones that are working the diagnostic equipment, the step, the otoscope, the exam camera in certain situations. And the physician is able to receive those images and receive those heart and lung sounds in real time and make that assessment for that plan of care. But as far as workflow, we can dive into that. I know that can be a cumbersome process. everything from scheduling the patient all the way through the end of the consult. So,
yeah, just to concur with Jason, we used a lot of the same processes, and when we're working up, an idea for a telehealth program, I do have a Six Sigma black belt, and we really focus in on, what is your current process to see these types of patients in this type of clinical program, and what would be ideal. And we really get down to the detail of mapping that workflow up front to say, all right, is this really going to be easier for the patient? Is this going to be better for the health system? Does this eliminate waste? Is this a leaner process and a more patient-focused process? So doing that workflow up front is key.
Okay, I think we're out of time at this point. We have quite a few questions. I think we covered all of them, but there might be a few left. So we'll take a look at the additional questions that are left and try to address those in a follow-up email to all participants. I want to thank you all for attending, and look out for the email that will include the archived recording of today's webinar. Thank you for your time. Goodbye.
Thank you.